Well, we're going to get right into it. Thank you again for joining the 5th session for ASTARISQ, our summer roundtable series. ASTARISQ stands for Addressing Systemic and Structural Racism to Improve Safety, Quality, and Trustworthiness in Health Delivery Systems. And our 5th session, which comes after our discussions on structural determinants of health, improving patient safety in health delivery systems, how to address systemic oppression and improving healthcare delivery, and whole person healthcare. I'm so pleased to welcome our 5 esteemed panelists to talk about tools for advancing health equity in healthcare institutions. Each individual will introduce themselves shortly, but I wanted to go over a few housekeeping items to encourage our attendees to use the chat and Q&A in order to encourage dialogue across today's discussion. And I also want to thank our funder, the Agency for Healthcare Research and Quality. Because this project is funded under ARC, the authors are solely responsible for this webinar's contents, findings, and conclusions, in which they do not necessarily represent the views of our funding agency. You should not interpret any statement in this report as an official position of ARC or the HHS, and none of the authors have any affiliation or financial involvement that conflicts with the material presented in today's session. So again, encourage all of you to send us the tools that you've been using to share your reflections, whether that's been from attending all 5 of our summer roundtable series this year, or this is your first one. We're really looking forward to today's dialogue. So to get into it, I'm going to ask each of our panelists to introduce themselves and share what's one goal they have for participating in today's discussion. And I'm going to ask Lou to go first. Lou?
Hello, everyone. Good morning to the West Coast colleagues and good afternoon to the rest. My name is Lou Hart. I am a pediatric hospitalist at the Yale School of Medicine and Yale New Haven Health. I also serve as the medical director of health equity. I'm really excited to be a part of this esteemed group and to be able to really engage in what I think is going to be a very fruitful conversation. I think what I'm looking forward to most are those concrete action items, whether that's through policy change or through an action that we can take tomorrow to really put forward a purposeful tool to advance health equity within the sphere that we have full control over, and that's our day-to-day. So I'm really excited to be here, and I cannot wait.
Thanks, Lou. Mo, do you mind introducing yourself?
Thank you, and good afternoon. My name is Mo Barbosa. I serve as Senior Director of Community Engagement at Health Resources in Action, work with many hospitals as they attempt to address health equity in the spaces that they are serving, and also spent about 10 years on the board of a public safety net hospital. I'm really excited about supporting these conversations and hearing what my colleagues have to share, but also what your questions are.
Thanks, Mo.
Thank you.
Deanna?
Hi, everyone. My name's Deanna Williams. I use she, her pronouns, and I'm a research investigator at the Institute for Research and Innovation at MultiCare Health System, and we're a community-based health system located in Washington State. My background is in public health, and I also lead the health equity research program at our institute. All of my research focuses on advancing health equity, primarily for LGBTQ+ communities and communities of color. And I'm really excited to be here today. I think my big objective is to hear everyone's big wins. I think it's really great to get to learn from the things that have been most successful in the work that we do. So I'm looking forward to hearing about that and sharing some lessons.
Thanks, Deanna. Matt?
Hi, everybody. I'm Matt Edick. I'm the director of the Center for Precision Public Health at Michigan Public Health Institute. My background is actually in genetics. I feel like maybe a little out of place sometimes in these conversations. I studied genetics and cell biology for many years. But about a decade ago, I got involved in public health and public health genetics. Have a team of almost 40 people at MPHI, and we have a lot of work in the space of precision public health. But the work that intersects, I think, the most with this conversation is our work in access to healthcare. Do a lot of community engagement, a lot of provider education work, all aimed at improving access to healthcare. So I don't know that I have anything to add to anybody's goals for the conversation, but I certainly am looking forward to hearing what everybody has to say. I love being able to participate. And Hillary, thanks for the invite.
Absolutely. Thanks, Matt. Tatiana?
Thank you. Good morning, good afternoon, everyone. My name is Tatiana Bustos, she, her pronouns. I'm a public health researcher at RTI International. I sit in the Transformative Research Unit for Equity. And there, our work is really building out research, equity-centered research that is challenging mindsets, beliefs, structures for how we typically do research and evaluation and technical assistance. I'm a trained community psychologist, so a lot of my background is in community-based participatory research, have been engaged with health equity initiatives in different ways, different contexts, and different communities. And I have a very deeply vested interest in this space. I think about how I'm driven by my family as I approach health equity work. And the idea, what I hope you all leave with today, or the objectives that I'm going to add to the conversation is, again, hearing from everyone, but also hoping that we can think about how intentionality is part of the process to health equity in terms of, from the researcher's perspective of designing work that gets scaled up. And so I'm looking forward to this conversation.
Thanks, Tatiana, and thank you again all for being here. It's great to also see the introductions in the chat from some of our participants, those who are coming from clinical trial experiences, patient advocacy, and research, and really looking forward to engaging all of you who are online in what your goals are for today's discussion. So as I mentioned, this is the 5th of our health equity series, and we've been talking a lot over the past month about the critical issues, whether that's the barriers, the successes for achieving health equity. So in your eyes, and I'm going to pick on Deanna first, what are the mandatory components for achieving health equity?
Thank you for that question to start off with. So when I think about health equity, I can't even start the conversation without thinking about intersectionality in framing our work. I think that an intentional focus on intersectionality and thinking about how all forms of oppression are linked is critical for us to be able to advance health equity, because it's not only a lens for making oppression visible, but it's also a tool that we can use to dismantle it as well. So for instance, in my maternal health work that I do in the research project that I'm leading, I can't think about structural racism without also thinking about heterosexism, without also thinking about sexism that's impacting the lives of the women of color that I am aiming to improve their healthcare experiences. So I think really being critical about making sure that we're understanding how all forms of oppression and power are ultimately linked and uphold one another is really a critical tool for us in this work moving forward. I think really intentional partnerships with the community, and I know that we're going to be talking about community engagement and community advocacy moving forward, but the community has been doing a lot of this work longer than a lot of us have, and they have insights that we simply cannot bring to our work without their partnership. We can't do this work in silos. We can't do this work alone. So absolutely having equitable and intentional grounded community partnerships is critical too. And then the third point that I'll make before passing this on would be reflexivity as we do this work. And reflexivity really is that intentionality that Tatiana was mentioning. It's about having the tools and the skills to be able to reflect and be critically not just aware, but then to turn that into action of our biases, our values, our positionality, where we're coming from, why we do the work we do to begin with, why we're choosing to focus on the populations we're focusing on, why is this the aim of our research studies, right? So all of the thoughts that go into the way that we shape our work, those are things that we have to be critically aware of and reflect on with cultural humility again and again and again, so that we're aware of the impact of ourselves on this work too. So those are the three things that I think are core components to moving this work forward.
Thanks, Deanna, for kicking that conversation off. Others? Matt.
I'd be happy to chime in. As I think about the work that I do, for me, a lot of it is not at the system level. It's mitigating impacts and effects of lack of health equity. And when I think about what's missing, so that I don't have to do that work that I'm doing, I usually land in the system somewhere. It's policies that have been in place and deeply rooted in oppression for however long an organization or institute has been around. And so I think for me, one of the key pieces of achieving equity is having people, maybe like the folks on this call, who are willing to challenge the policy, that have the right power, the right influence, know how to have the conversation to really impact policies and structures that continue to perpetuate oppression and lead to health inequity. So for me, that's a really big piece of this. And I think we get to talk about that maybe a little more later. But
Thanks, Matt. Mo.
I'll just add quickly that, in a space where race continues to be a predictor of bad outcomes, we cannot do health equity without racial equity. And that focus and that willingness to address racial equity allows us to bring in all those other social determinants of health that affect and impact those populations, that then shows up in their health. Their poor health outcomes become seen as symptoms of a bigger problem. And if we are really looking to work at the population health level, then we really have to address the social determinants that are affecting racial equity as they then impact health equity. So if you forget anything else, you can't do health equity without racial equity in America.
Thanks, Mo. Lou or Tatiana, other components that are critical for health equity you want to share?
I was just going to add I think about community power and capacity building. So oftentimes, we have all these really great programs that focus on policy or systems level and forget to build self-determination into the broader community so that they can drive those actions without us or without the program. The ultimate goal is for communities to drive the wheel and be able to critically be aware of those disparities or how those social determinants of health impact their lives. And so something I'm trying to be more explicit about is how can we ensure we're putting in the opportunities or contributing resources to make those opportunities happen for capacity building in different ways that generate power in communities. They have that power already. It's dormant sometimes, and it's a matter of how can we set them up for success in different ways and make that power come to life, if that makes sense. I often think about that component as a mandatory and necessary for health equity to be sustainable in the longer term.
That's so perfect, Tatiana, and I couldn't agree more with most of it, pretty much everything that everyone said. I think the only piece that I'll add, and maybe it's pragmatic, and maybe it sometimes gets a bad, because it is so perverse, it's financial incentives. Right now, there's very little financial incentives in the short term for many to think that this work is important to their bottom line for the next quarter, for the next handful of quarters that they're going to be in power. And when the status quo is benefiting those in power so much, it's hard for all of us to hope that someone will think of collectivism as opposed to their own bottom line. The selfish gene, we all have kids or family members that we want to care for. We all want to make the world a better place in our own lens. So how might we be able to make the financial incentives a little less perverse? In America, we don't really have a healthcare system. We have a sick care system. There's little profit in keeping people healthy. There's much more profit in treating chronic disease or in specialized care when disease is really late. So how might we be able to think about creating a profit incentive, not just for the centers of profit right now, but those profits, like Tatiana was saying, in the community, where there's a lot of great community-based organizations that are doing amazing social care. Why are we not why are they not benefiting so much from their innovation and from the amazing work that they're doing? And how are we not funding that through a healthcare system that combines not only Medicare, but social care to truly deliver health outcomes to the patients that at the end of the day, we're all paying for this, whether that's out of our employers' paychecks, whether that's out of tax dollars, or whether that's out of busy emergency departments because how we mismanage healthcare in this country. It's going to come back and bite us all in the end. So it's important to realize that we're all in this. But how might we be able to make those short-term financial incentives a little bit more apparent? And we'll touch on this a little bit later. A lot of the work that's happening at CMS, a lot of the work that's happening at Health and Human Services, at the Joint Commission as a national patient safety goal, to really rein in the accountability and to really call people into account for how we've always managed healthcare in this nation and how we might be able to, craft a new destiny moving forward.
Thanks, Lou. Yeah, one of the things we talked about in our prep session was, while there are these structural challenges to achieving health equity is a hot topic. And I think, Mo, you even said something along the lines of, it's popular to have the conversation, it's less popular to actually do. So, despite these barriers, and many of you have been able to address these in your own organizations, in your own communities that you serve and you work with, how can we move from thinking about health equity to truly doing health equity? And Mo, I'll start with you because you mentioned you can't do health equity without racial equity. So first from you and then hearing from others, how do we move the needle from thinking to action?
Thank you. First, we have to set the goal as not learning, but doing. So that's the first thing, that our institutions need to name the inequity that they are addressing, the target change that they are looking for, the quarterly change that they expect and what the work is, and be able to account for whether or not they've reached those goals. Just like we would do with any other metric at an institution, we need to have inequities be addressed in the same way. And that means, doing some deep diving into where are the folks who are experiencing the inequities, what is the opportunity that the institution has, where has the institution done less than where they should be, and then what do we need to do to change to be able to meet that metric. But if you're not setting a goal and a metric, then you're never going to get beyond conversation. And it's got to be from the top down. It's got to be at the board level. It should be in your strategic plan, and you should be reporting on it quarterly.
Thanks, Mo. Tatiana, I know you've done a lot of work when it comes to metrics, program evaluation, capacity building. What are some of the implementation strategies that you've seen for being able to sort of address some of the recommendations that Mo shared?
My first thought was the idea of sustainability and having that conversation early on in connection to equity, because sustainability of a program, initiative, or partnership, it has a lot of implications for equity in the longer term. So even, and it's not a strategic plan, it's more like a sustainability plan that goes along with evaluation monitoring, where you are embedding those metrics for what it is that you are putting into this evaluation or project to ensure that you're moving towards more sustainable outcomes. So I think that was the first thought when Mo was sharing. It's like, oh yes, perfect. Yes, I love the idea of making it so concrete and tied to like specific implementation factors that we know, like that framing might work better, and just incorporating those equity metrics. The other piece about it that made me think about is how sometimes we often sit at different levels and we don't have those opportunities to set those objectives. Sometimes we're just the client's contractor and they're setting these objectives for their broader organization. And one contribution I wanted to make is thinking at that individual level, like what can we do, is being brave in making that change. Like if that's a conversation that's never been had because the organization has already set their objectives, can we ask a question and start that conversation? And that's something that I also try to embed in my work, where I'm not just doing the bare minimum. Like I have to do beyond and challenge whatever structures that we're typically used to, so that we can get to a place where there are new metrics that are more explicit about equity and things like that. So I also wanted to add that.
Thanks, Tatiana. Deanna, Lou, Matt? Strategies for action. I know, Matt, you've done a lot of workshops also in capacity building and building relationships with community partners. So tools that you can share with the group?
Yeah, I mean, I'd be happy to chime in. I was thinking about this question really from two approaches as I sit inside of MPHI. One thing that's been really effective for us in terms of putting equity into practice is having the fortunate space of sitting in a public health institute. Equity is very important. Social justice is very important. And so it's really easy for us to have institutional policy that allow us to, for example, engage communities in this work in real and authentic ways and give them power. Tatiana, like you were speaking about, communities have this sort of dormant power, but we need ways to bring that out. And so, in that space, and I do give a lot of credit to MPHI for this, for making it possible for us to do the work. But as you mentioned, Hillary, we've done a lot of different workshops with patients of certain conditions, with healthcare providers, public health folks, just around having these conversations about equity, having conversations about oppression, about racism. How do you have that uncomfortable conversation? How do you have it when there's a power dynamic? I sit in a position of power at MPHI, and I work with lots of people who have no power, or at least they feel like they have no power in any space. And so we've just done a lot of work in learning how to give people that power. And then one thing I just wanted to follow up, and I was thinking about it from your earlier comment, Tatiana, about giving communities power. We also find that we can't just unlock the power and let them go, but we do have to step out of the way. And that's a difficult balance to, help unlock the power, support the community to drive the change they want and need, and not inadvertently be directing the change that we think they need. So it's been an interesting journey for us in that space of how to do that well. And I'd say we're still learning.
Thanks, Matt. Deanna and Lou, one of the things that's come up a few times, even just in the stories that were shared, is community engagement and what authentic community engagement looks like, and how do you make it happen? So Deanna, take it away. Community engagement.
Yeah, so actually this is kind of a segue from the previous question as well into this question. And I think something that I think about a lot is how we are compensating, how we are investing in the communities that we're engaging with. And I know that Lou kind of touched on this as well. I think a lot of community engagement work and a lot of, community advisory boards and community steering committees are doing unpaid work. And that is not a part of an equity building process. We need to be compensating people for their time, for their energy, for their expertise, honoring and valuing their lived experiences. And that goes into kind of moving from thinking about health equity to doing it because we need to put our money where our mouth is and put our money into actionable change. And a part of that is investing in our communities. When it comes to community engagement and building trust and trustworthiness, a huge part of that is showing up. It's showing up outside of research context. It's showing up to community events. It's showing up virtually. It's being there. It's being embedded in the community. It's about demonstrating and revealing yourself as a trustworthy person, not even attached to like your program, your research, or any of those things. Being part of the community outside of that is powerful and then opens the door to being able to collaborate on these programs or being able to collaborate on a research program. It offers kind of like a pathway to developing and sustaining that work. So I think I would say all too often people go to the community with a goal in mind of what they want, instead of allowing it to be an open space for listening and for learning and for generative collaboration. So approaching those collaborations with the space of openness and wanting to learn and wanting to be there and wanting to support and wanting to invest, I think goes really, really far in building trust.
Thanks, Deanna. Lou?
It's so interesting. Again, very well said, Deanna and team. I just think like when we say community, like, is that a euphemism? Do we all have the same idea what we mean when we say community? Do we think of an inclusive community, those who might be against this work as a part of our community? Or do we just think, I don't want to speak to them. I'm only going to speak to those who I think this work might benefit, even though we all know this work will benefit us all. So I think it's like really important to call that in. And I think, we describe transparency drives accountability. We think about it in quality improvement and patient safety. It's the domain I sit kind of within clinical operations in a health system, kind of at the end implementation of quality care. And at the end of the day, like, what data do we suppress? Well, the data that doesn't make us look good. I mean, that's just human nature. What data do we tell the U.S. News and World Report to write a story about? The data that we want, the stories that we want to tell. And I think, I'm nowhere near the academician that my colleagues on the call are, but I think about, like, when I publish a really high impact paper, it goes into a journal that's behind a paywall that none of my patients will ever read. Only other academicians who like the title will also read it. So think about the privilege of me taking tax dollars, working at a tax-exempt institution that accepts NIH funding to publish stuff just for the elite. I mean, how am I serving the people that are having their local tax dollars not be invested because we are a tax-exempt organization? So I think it's, like, really important to understand, I might have a much better impact as a researcher publishing with a community member who can speak to the real lived experience, as opposed to me thinking I understand it, or maybe I have a relative, or maybe it's something that I can reflect on. Right now, I sit in a position of privilege, so a lot of my bias is influenced by that privilege. So yes, I want to share it, but I have to be humble to understand that I do not know most communities' issues, only the community that I grew up in. And I think the other piece that it's really important to that kind of earlier point around the euphemism, like, it's so funny. Like, I've been in the health system for 3 years now, and I served in another not-for-profit, New York City Health and Hospitals, nation's largest comprehensive safety net healthcare system in New York City. And 3 years I've been in this role as the inaugural medical director of health equity, and just speaking to, like, community education, internal community. 3 years later, I work within clinical operations, quality and safety, and people still say, Lou, like, you lead DEI work for the health system. And I go, like, well, if, like, improving the quality and safety of our patient care, unwanted variability in care is DEI work, then, like, I'm pretty sure we all do DEI work by that nature, by that definition. So I think it's really important for us to, we make a lot of presumptions that when I say community, you know what I mean. When I say health equity, you know what I mean. And I think it's just as important to kind of think of this through, like, a targeted universalist approach, understanding that, like, the majority of the room might be against this work. And how are you bringing them along the journey? Being strategic and understanding that I'm going to present an opportunity to improve your experience, your outcome. It's also going to help a whole lot of other people. And we're actually going to focus on how we're going to help those other people. But the things that we learn from how we might be able to advance a priority population are ultimately going to come back and reward you. So we are all in this together. Again, speaking to that approach of kind of collectivism. And I just think when we say community, and this is my own bias, I just assume probably the most disenfranchised, those who are living at the lower rungs of socioeconomic status. And that is just but one community that lives in our nation. Yes, that's a community that hasn't been prioritized, but we don't want to be ignorant to, the elephant in the room of who is the community of power and how are we speaking to that community, maybe just as well. But at the understanding of who we are trying to advance, we're trying to advance all of us, and making that really clear that we're not trying to rob Peter to pay Paul. I don't know if that term's appropriate, but we're not trying to take from one to benefit another. And I think that's been the biggest pushback against DEI or against affirmative action, that we're robbing one group to benefit another group. At the end of the day, we're trying to make a system that's better for all of us. We're trying to grow our bench and trying to grow our capacity so that we can all benefit from that outcome.
I know a couple of our panelists definitely have some responses for you, Lou. I'm going to ask Mo actually to chime in, because I think you're also, again, you talked about racial equity. I agree, Lou, that it's easy, and even with community partners here at the University of Maryland, Baltimore, like, when you say community, are you just talking about Black people in the community? Or are you talking about West Baltimore? Like, we are not good at defining and also recognizing how diverse a community can be, that there's no state, right? Even if you have a community, it still has many diverse voices. But Mo, tell me a little bit about what you're thinking here.
I think there's an importance in understanding that while targeted universalism is a goal we would all like to get to, we can't keep on, dying disproportionately until we get there. And so it may mean that we need to, I think you said, rob Peter to pay Paul. Paul's been getting robbed for 400 years. So we might have to do it in the other direction. And to the extent that, there's a pushback that folks don't want to rob Peter to pay Paul, it's been unfair by design to this point. And so we can't be afraid of pushing back on there. Now, it will take time, and we're going to figure out which battles we can win, but we can't decide to not do that part because it isn't the greater good that we want at the very end. We need to address the inequities that are in our space right now. And often when we're saying community, we do actually mean the people who are being harmed the most, and the folks who are most on the margin. And so we need to actually say that we want to center those who are being harmed, those who are suffering inequities. We want to center their experience here so that we can address that, because we are complicit in what has happened to them and continues to happen. And as we address that, we can move forward from there. And Lou, I don't disagree with everything you said there, but I think there are moments where we need to actually step forward, and where institutions need to make some of those bold steps. And, you know, I'm looking at your background where Yale has done that specifically. So I think we need to hold up those examples where folks have taken those steps forward and said, we are going to plant our flag here for this purpose in service of this population, and we will get to everyone else after, because things have been so egregious so far.
Thank you, Mo. Matt?
Yeah, thanks, Hillary. I wanted to follow up on Deanna's comment about compensating community members. This is something that's always been really important to me, even before public health, as a researcher, and then definitely my work in public health. And a few years back, I got a little bit of a wake-up call in this space. This always felt to me like a space where, like, this is a universal truth. Every time we're working with community members, we should be compensating them. And I learned that this is really not always going to be the case. It's really more of a both and. My team does a lot of work with plain communities, so Amish, Mennonite, Hutterite communities. And what we learned through engagement with them and the work that we did is it's actually culturally irresponsible and even somewhat offensive to individually try to compensate them for participating. And this was, I mean, I guess it sort of sounds simple, but it was a blow to our paradigm of this wonderful work engagement that we've been doing, and thinking we were being equitable and thinking that we were being authentic. And so I wanted to raise that just to remind us all, and I hope I'm preaching to the choir a little bit about this, but one size only fits one. And even with some of the most simple things like compensating communities, you know, in this case, we found a way to do that differently, but it's nothing we ever had done and nothing we had in place. You know, instead, we're making contributions to the broader community, which in those plain communities, that's how healthcare decisions are made. They're community funded. The communities all kind of participate together in making community decisions. So we're able to compensate at the community level for that individual involvement of the community members. But I wanted to highlight that as just, you know, one of those little nuances where we as professionals have to be a little bit careful about falling into the ruts of doing what we've always done, or kind of one size fits alling things that we maybe don't realize don't fit all.
Thanks, Matt, for that. And Mo, Lou, Deanna, Tatiana. I mean, you raised the point that there is, right, a one size fits one, but also that we can never determine what the community or communities we serve wants, because each one is going to have a different priority, right? It's about having that continuous conversation and revisiting the agreements that maybe you make with your community in order to encourage sustainability. Because as people grow, as we change, as our life circumstances change, certainly our priorities may change too. So again, I appreciate the dynamic and diverse conversation each of you is bringing to us today in order to see, like, what are the solutions. And, you know, one of the things that I often hear, again, working at an academic institution, it's, well, let's look at the data. What does the data say? And data can be used both as a transformer for addressing barriers to health equity, but it can also be a maintainer to inequities. And so I would love to hear from those of you who either sort of have thoughts or how you use data as a transformer to improve health equity, and what are things we need to be wary of when we work within these systems and our colleagues say, well, that's not what the data says. We shouldn't make that a priority because that's not what the data says, even if that's what we hear from our communities that that's what they need. So anyone want to dive into data? Oh, and that's a great point, Matt. Yeah, Tatiana.
I can kick us off. So something that I just wanted to make a comment about Matt's experience. That's something that we've also seen, and how compensation can have implications for the public benefits that folks get. And so equitable compensation is definitely an important conversation to have. So data. So something that we try to think about is the research enterprise as these three components where the person who has control over the data or is collecting the data or making decisions about what data to collect, that is very important to going back to Deanna's point about reflexivity to maintain these specific reflections and protocols or debrief protocols about why it is that you're making those decisions. Why is it that you're collecting this data? Are there other ways, other forms of data that you can actually consider? So that's one of the first steps. And people don't necessarily like to think of that, especially well, I don't know. Some quantitative researchers tend to think that the individual is separate from this. It's an objective process. And in fact, that's not true at all. We're all part of that process. And our biases are embedded throughout as we're making those analyses and making decisions about, what information to present. I think Lou was the one that mentioned that we only present what makes us look good or something like that. And that is important to think about from the very beginning as you're designing and working with data. And the other piece about it is also how the data is collected. So, going back to what we were discussing about community engagement, if we're collecting data directly from communities, how is it that we're approaching those communities? Are we being inclusive in terms of accessibility, the plain language, the spaces that we're using to have conversations with communities? Because that often leaves out an entire group, and your data is biased already because you're missing the perspectives of certain populations that actually have a voice and should be part of the story related to health equity. And then so that's the second component. And then the last component is how it is that we're actually making interpretations based on the data that we have collected. So in the sense of language, like when we collect data related to health equity and we find that there's racial differences, there's differential differences between demographic groups, and that's all we say, and we don't make a connection to the systems and how those systems are contributing to those differences. That's something that we can easily do in our interpretation process and how we're framing the data, and in those reports, in those papers to clients about what it is that we're finding in terms of the disparities. So those are just some quick openers for folks to discuss.
I can hop in next to kind of build off of some of that. And thank you, Tatiana. I completely agree. I think with thinking about the way that we are presenting our data, to your point, I think that there's a lot of ways that research does a really bad job of connecting disparate outcomes to social identities and to trying to connect and frame things in a way of, Black people, Black women have worse maternal health outcomes because they do, right? And not situating it in that larger context. But I think also as researchers, we have to be really careful about making sure that we are not framing communities as if they only have health disparities, right? We know that in order to address health equity and racial equity, obviously we have to address health disparities and racial disparities. But it's a careful balance also between making sure that we're recognizing the assets and the power of communities too, and highlighting the ways and the nuances that communities are also thriving, and highlighting their strengths and highlighting their persistence too. So I think we can't shy away, of course, from the disparate outcomes that are happening, but in that same breath, we have to make sure that we're not presenting communities as in like communities don't have power, because they certainly do. And I think a second component that I would say, Tatiana, I am a qualitative researcher, so I have a heart for storytelling and for narratives. And I think being able to interweave in those nuanced stories of how people are experiencing their lives and how people are experiencing systems is critical to using data better and also moving people to change. I think it can be easy for people to kind of take a glossed over look at data sometimes when they're looking at solely like trends that are happening, or maybe we have panels on our electronic health records that are showing us certain measures and metrics. But I think also equally important is having the story behind why those numbers are the way that they are and what people are experiencing that has contributed to some of those outcomes. And then finally, my final point would be returning the data back to the community is how we can also use data better. Kind of to points that have been made, we oftentimes have a lot of like elitism within research and within academia, and research papers, being behind paywalls and having research being written and disseminated in a way that folks don't read, that's inaccessible, that folks can't even access to begin with. So thinking about what are ways that we can make sure that the community have partnership in this process, that they can use the data in ways that benefit them, and that we can also share data in a way that makes sense for folks too. So I would add on those points.
Thanks,
I'd
Deanna.
love to chime in on Deanna's coattails about that accessibility of the data. This is a really big issue. I think there's all kinds of statewide surveillance. There's all kinds of survey data all over the place. And it's not just putting your hands on those data. It's not just handing those data back to the community, but also making sure it's handed back to them in a way that they can use and understand, and that they're given the tools to use and understand it. And I'll stick this in the chat. My team did a project a few years back funded by CDC, where we took surveillance data, statewide surveillance data from ED, like syndromic surveillance, and then also just like youth risk assessment survey data. And we built a dashboard that, much to my team's chagrin, I required the audience to be everybody. It couldn't just be epi folks, it couldn't just be community, it had to be for everybody. And so I'll put that in the chat. But what we really strive to do was present the data in a way that it didn't matter who showed up, they could look at it and see it and understand what that piece of data was maybe saying, but then also included call out boxes that you could click on that would help to know what you do with these data. So, if you look at this data point and it says that, I don't know, one group is different than the other group, here's what you can do about it. And, here's the types of things that impact this particular graph and this particular data, so that communities have the power to make the decisions to do the things to improve health inside of their communities. I think when we have conversations about that data accessibility, even with our funders, that data literacy piece, I know I saw a few people talk about health literacy, but that data literacy piece so often overlooked. If we don't address or at least cater to the literacy levels of our communities, then we never achieve accessibility. I can pour it in your lap, but it doesn't really mean anything, right, if you don't know how to use it. So it's a little passion space for me. Sorry.
Thanks, Matt. Yeah, and certainly resources are always helpful, right? But it's not impossible to make change. It's not impossible to address structural racism within health delivery systems. Each of you is doing that, as well as many of our attendees. We could certainly talk about this for many hours, but I do want to take a few of the questions that have come in through our Q&A and from the chat. And so the first one that I have is from Bill Freeman, who's actually our program officer. So thank you, Bill, for all of your support for Asterisk. His question asks, how do we find the right voices from communities when we engage them? If we go to community leaders, they are already in positions of power. What about those who are not part of community organizations, and how do we hear their voice? So suggestions, are there things that have worked for any of you as you've been doing community organizing to, again, get those diverse voices from within communities more within the conversation? Mo.
I'll give you 3 quick examples. One is you have community leaders, have them be the conduit to community members instead of speaking for community members. So say, hey, Bob, bring me 3 people who are experiencing this instead of having Bob speak for those 3 people. So that's a first one, that those community leaders should really be the conduits. They shouldn't be replacing. Second is that you don't want to be talking to community just when you need their voice. You want to be talking to community all the time so that you're engaged. You're not starting a conversation when you need something, you're in a conversation and your need comes up. So you're building this relationship over time, and you're engaged with folks as regular opportunities where the institution is talking to community members. They know when it's going to happen, you know when it's going to happen. And when it happens, you might bring the latest thing that you need, but you're in a long-term conversation, a relationship with the people who you're serving. And then use the institutional structures that you have to build the leadership of community members so that they can go from being in a community input space to some point being on your board, and having community members on your board as a, not just as a patient, but as someone who lives in the community that you're trying to address. And where are the structures along the way? Where are there levels within your institution? So if you're at a hospital, it doesn't have to go from I'm in a focus group to I'm being asked to join the board of directors of the hospital. There are other spaces along the way where engagement can be a part of that. One of the spaces that I spend a lot of time supporting hospitals doing is having community members and community members, broad sense, residents, community-based organizations, et cetera, be a part of how the hospital makes decisions about where they make non-clinical investments, community benefits, anytime they're giving away money, as a training ground for folks to be engaged in these spaces. And you're building the leadership of folks so that they are ready when they are ready to go, as well as when you need them.
Thank you, Mo, for sharing those strategies. Other examples folks want to share? Tatiana?
I can share a tool. So I actually put together a training on this because, to Mo's point, it's very important that we're fostering, initiating, making those relationships, growing those relationships over time. So I call it the pre-work, the pre-commitment of what you need to do, because that has to be in place from the very beginning and throughout. But just thinking more practically about tools that can be helpful as well once after you get to that point is partner mapping. And the reason I bring partner mapping into this space is because oftentimes we forget to match certain names to the perspectives that they're bringing that are part of the system. Like social issues are part of this dynamic set of systems. And where do these perspectives of individuals fall in that system? And so there's a framework that I put together in terms of there's people who are directly impacted, there's the folks who are the providers, and the other folks who drive the decisions for funding. Where do these groups fall? And just thinking more intentionally about those perspectives, because we might find that the groups that we are often reaching out to and inviting into this space are folks that aren't even at the center, or because those are often challenging to get. And maybe that can inform our continuous improvement process to prioritize those perspectives more next time. And so there are tools out there like partner mapping. There's lots of different versions of it that help us think about those perspectives and where they tend to fall in the system. And then also I put together this decision-making framework about how do we choose which one is the best, or which perspectives haven't been voiced yet. What are the decision points that we should make in terms of pursuing this perspective or group. And so I think having a more structured process for your team, your context, your project would be really helpful, because we it is oftentimes, as from the researcher's perspective, haphazardly set up, and we're pursuing these different community groups without necessarily thinking about those nuances. And so it's just really important to take a step back and be a little bit more systematic about it, just from that researcher perspective.
Thanks, Tatiana. Lou or Deanna or Matt, yes.
Yeah, I just would add yes to everything that has been said. But one other thing that I've found important, especially in our work in rare disease. So I'm a parent of a child with a rare genetic disease. And so I'm part of that community of people we're often engaging. And it gave me a little bit of perspective about understanding and recognizing when we're in an echo chamber, hearing sort of the message that maybe the national org is pushing or the local state org is pushing, and how that doesn't always align with what I don't know what else to call it other than what I think of as like the real family, the real patient, the one that isn't a national advocate, that doesn't have all of those resources. And often they're different. So I think we have that responsibility to always be vigilant of the echo chamber and make sure we're not in it. And I think much of what Mo and Tatiana shared help us get to that space of making sure we're not. But I think we also need to be vigilant to recognize if we are.
That certainly speaks to one of the components that Deanna initially shared, which is about reflexivity, right? It's continuing to be curious about where our biases, where our intentions, where they're coming from, asking questions to those to either, again, triangulate or member check for those researchers in the room to figure out, like, are we on the page where we need to be, or are we grounded in the partnership work that we are all trying to do in order to achieve health equity for the various communities and various populations and people that we serve. There have been some really great resources that have been shared by our attendees in the chat. And again, really encourage the conversation to continue beyond today. And again, thank you all for encouraging this discussion. I did want to answer, we have a couple more questions that have come in through the Q&A, and one of them goes back to sort of sharing what we're learning and translating evidence. Lou, you mentioned, right? Often when we finish a big project, we will go to publish it in a peer review paywall setting. So how have you translated scientific publications, results, the sharing and celebrating of the community partnerships that you've done into plain language or into spaces that are open access that then can be shared more widely? So Lou, I'll sort of ask you, how have you addressed this, since you're the one who brought it up in the first place, and then to others, how do we translate the scientific work that we do and create that open access availability for all to be able to advance our work together?
So it's interesting that you ask, and this is definitely learnings that I'm taking. I'm now a second year student at the School of Management, getting my executive MBA, and the two cheapest but probably most effective forms of communication to create a market are word of mouth and social media. And so, like, how might you be able to use those existing partnerships that you have through your CHNA or your CHIP to then be able to like, we recently launched a We Ask Because We Care campaign, and it's around demographic data collection and why it's important. But since we had a marketing budget, which allowed us to get on the radio for airwaves, which allowed us to get into print media, local newspapers. And as opposed to just talking about the campaign, we talked about some of the successes of the campaign. We interviewed patients. As our health system grapples with the flaws of the convenience sampling that is race, and using that as an immutable proxy for biology, and the downsides of, when we find a difference between racial groups, saying, well, this must be biologic, thus we should treat all Black people's kidneys differently than non-Black people. As we kind of unwind some of that race-based thought, we were able to highlight the story of it was actually a staff member who, because we were using a race-based version of kidney function, EGFR, they were denied access to the transplant list. And because we had updated it, we were actually able to buy them 3 years back on the transplant list, and they got a kidney a couple of weeks later. They were on dialysis. This person was about to probably not be with us anymore. So we were able to like highlight and prioritize the stories of actual people that were impacted by this work. This campaign was around data collection, but we really showed it in a way and in different forms of media that allowed people to not publishing it in New England Journal, but publishing it on our website, publishing it on social media, putting it in the local newspaper, having a radio airwave during rush hour. Most people have to commute to work who are essential workers. They're probably tuning in. They might have an opportunity to engage in this content that they never otherwise would have. So we understood that, once we're able to get, again, hopefully making it in a digestible way, it would then be able to spread throughout the community. And then our community members, and I mean all community members, could hold us to account for what we were doing, often behind their back, and treating them differently on the basis of their skin color, because that's kind of what the biomedical researchers showed us, as opposed to the biomedical researchers saying, well, race is playing a proxy for racism, and it's actually discrimination of this. So that's something we can do something about. We can't change people's skin color. We can't change people's experience of racism. We can't just tell people to be less racist, but we can intervene on the ways in which racism is showing up and impacting our patients. And that is something we absolutely can do. So that was one very effective campaign that didn't cost us that much money. And we were able to get a message out outside of a paywall that I think was very impactful for our broader community.
Thanks, Lou. Any of our other panelists want to chime in for how do we share better the work that we do?
Yeah, I can chime in on this. I think one thing that I would say that I have found has been really, really helpful, and this kind of, again, goes back to community partnerships and community engagement, is ask the community what they want and ask the community how they would like to see this information out in their spaces or shared with their circle, themselves, other members of their community organizations, because my colleague and I, who lead one of our community advisory boards, we have time dedicated to this where we talk about what spaces, what places, what mediums, what people, like what does this plan look like? And we develop that out together, because I think coming into that as the researcher, we have obviously thoughts and ideas about what might be the best places for sharing. And then we hear from community members, okay, but if you're sharing only on this type of thing, what about people who don't know how to use social media? What about people who don't have access to computers? What about people who don't go to this type of community-based venue, but we know people go here? So I think really tapping into and valuing and uplifting that community voice and perspective is really a beautiful part of grounding where our dissemination efforts should go. Because at the end of the day, even sometimes with our best intentions, we can still share things back in a way that people aren't going to use them and aren't going to access them. But our community folks can tell us what ways it could look like for it to actually be valuable for them.
Thanks, Deanna.
I was just gonna add, we actually did Mo, did you want to go? I'm sorry. I was just gonna add really quickly. We actually did a study on dissemination of academic researchers in the Flint community, and on the opposite end of things, what is it that practitioners, researchers need to do this successfully? And we found that some of the challenges that they had shared was not having incentives to do this type of work because of all the constraints and obligations that they have as part of their institute and role, which is fair. And so that requires training and understanding what is the value of sharing it with community members. That may come apparent to us, but not as much to other groups. And then the other piece about it was not knowing how. So oftentimes the academics, researchers are trained in developing manuscripts and scientific publications very well, but Lou, your example of radio messaging is very, very different. It's a rarity to have that opportunity to understand how to do that effectively. And so I would say something else that's needed to do for doing this type of work for broader audiences is really thinking about putting in resources to build out the capacity of those folks too who are responsible for disseminating products. So I just wanted to bring that up.
Thanks, Tatiana. Mo,
I'll
bring
be
us
brief.
home.
I'll be brief. Why are we doing it if it isn't for community to use? So ask that question. And so if you are doing something, you're doing it with, if not for, and by community. So the sharing is a part of what you're doing anyway. And always asking folks what they believe, think, and know about the issue before you share your results, and ask them what the results mean to them. And I always say, is this true for you? Is this true from where you're sitting, your experience? Even if they say no, that's a conversation to have about why, here's what the data is telling me and why you see it differently. Even if at the end I disagree with you about how you feel about it or what you think about it, I at least know why you see it as differently. So those two quick things, sorry.
No, thank you so much, Mo. And again, thank you all, Lou, Matt, Tatiana, Deanna, and Mo, for sharing your wisdom, your expertise, your lessons learned and promising practices with all of us today. Certainly, this is not the end of the conversation, though it is the end of the hour. And so we really look forward to continuing to engage with each of you so that we can continue to advance this work together. And again, appreciate your time this afternoon and looking forward to continuing the conversation through the fall and beyond. So thank you again for attending today's discussion. Thank you to ARC for sponsoring our Summer Roundtable series. And again, have a great rest of your day. Take care, everyone.